Hi everyone, my name is Ginger Johnson with Defined Health, and we welcome you to today's Insight Series webinar entitled Immuno Oncology Partnering Tipping Point or Tip of the Iceberg. Today's discussion will be led by Vice President of Defined Health, Jeff Bachman. Before that, I just have some introductory comments, and I want to tell you about some of our upcoming conferences. So first of all, we're pleased to take time out from our strategic business development consulting activities to bring you these Insight Series webinars as a way of showcasing how we think about and view various critically relevant topics for the biopharmaceutical ecosystem moving forward. Before I turn things over to Jeff, I want to note that early registration is open for our upcoming Cancer Progress 2017 conference in New York in March 2017, and there we'll feature sessions on the microbiome, aging, and cancer, exceptional responders, and valuing innovation in oncology, and that's just to name a few of the panel topics. So please visit cancerprogressbydh.com. It's up on the slide for more information about this, what we consider a truly exceptional two-day event. Also, we're sending invitations now to meet with our clients and colleagues during JP Morgan and Biotech Showcase, where Jeff will be leading a panel on next generation IO developments. And we hope to see you in San Francisco, so please reach out if you'd like to get together. To learn more about Defined Health in general, our capabilities, our upcoming conferences, please give us a call, send an email, or visit our website at definedhealth.com, and we will be happy to tell you more. So we hope to have time for questions at the end of the presentation. There is a method for sending those in. So send them in as you think of them. If we don't get to them in this hour, we'll follow up with you directly in the next day or so. And that would be Jeff will follow up with you directly in the next day or so. So thank you again for joining us, and enjoy the Insight Series webinar. And now I will pass the baton to Jeff.
Thank you very much, Ginger. And thank you, Javi, for all the technical help. So, and I appreciate all the attendees. I know we're getting close to the holidays, so it's gratifying to see such a large turnout. Certainly, if I were talking about non-immuno-oncology, I suspect it would be half the number of attendees, possibly. And we'll talk a little about that. That's part of what this webinar will try to address. So before we leap into some of the key attributes that underpin the deal-making activity in the space, which will be kind of the latter third of the talk, I thought it was important to frame the story by going into some of what's going on both in the marketplace and more particularly what is driving both the sales and the deal-making frenzy that's going on, which is really what's happening right now in terms of pipeline, both ongoing continued clinical studies of the advanced and approved agents, IO agents, as well as what's going on with earlier stage agents. One will see lots of different numbers, obviously, thrown around. One thing for sure, it's quite a large potential market, the immuno-oncology or immunotherapy market. If you use consensus analyst forecasts from Evaluate, you can see that although the percentage of the overall oncology market for IO still remains relatively small, the growth rate is tremendous, and I think we probably could all agree that's not simply a function of growing off a smaller base, but the degree to which the enthusiasm for these drugs, as reflected in the data that they have been generating to date and are continuing to generate, is really behind the interest and the surrogate of that interest that we will consider the sales to be. So whether it's 20 billion or 35 to 40 billion in 2022 or 2025, depending on what type of projections you see, it is certainly a tremendous and growing market within oncology, and again, the growth rate for the IO component of that is quite significant. Not surprisingly, of course, although there's quite a diversity in the pipeline, the advanced stage pipeline consists predominantly of ongoing development around the antibodies, the checkpoint inhibitors, the anti-PD-1 and PD-L1 agents, and certainly anti-CTLA-4, along with other modalities and certainly a handful of still extant vaccines that are in development, and we'll touch on that in a bit. But the vast majority of growth clearly is being driven by the approved modalities, which are increasing every day, but certainly between Ipi and Nivo and Pembro and Atezo kind of driving these original bulk of sales. And so the antibodies, the kind of readily available off-the-shelf that pharma is so used to are continuing to drive these. When you start to look at earlier projections, you do start to see some numbers showing up for some of the adoptive cell therapy, the CAR-T therapy approaches, and other modalities, but those are still relatively early in terms of analyst coverage, which certainly is what feeds into the evaluate pharma projections. And similarly, just like checkpoints are driving the majority of that growth going forward over the next, say, 7 to 10 years, the majority of that growth is coming in the established beachheads, if you will, of where the checkpoints have made their first forays, predominantly, though not solely, in tumor types that have been considered historically more immunoresponsive, or what we're often calling now more hot tumors, although not completely, because certainly lung cancer was not considered one of those historically, although as one thinks about it in retrospect, given the carcinogen-driven nature of it, the rate of mutations, and certainly the aspect of the infiltration in TILs and the correlation one sees there, that's, really maybe shouldn't be surprising. And also, clearly, lung cancer has a tremendous epi compared to many of these others, say the first indication being melanoma, where the magnitude is quite significant between those two. So the question we still get continually asked, both by industry players, peripheral players to IO, non-IO players, and people kind of outside of directly within industry, is why this frenzy in IO? Is it a tulip craze? What's really driving this? And I think the first important thing to note is that it's taken a long time coming. So I think part of the idea that's being a frenzy is driven somehow by the idea this is just kind of come on quite suddenly. Well, yes, the approvals only go back 5 or 6 years, excluding, say, approval of Provenge, but certainly starting with Yervoy and on. But the interest in the space has been very long-standing, and certainly there was a long and troubled history with vaccines, which has no doubt colored many of the conceptions and beliefs about the potential of immunotherapy or immuno-oncology, and continues probably to somewhat color people who continue to say, well, is it really that meaningful? Is it really having significant changes? And the bottom line is yes, and I'm going to touch on that again briefly just to make sure we're all on the same page there. But I also want to emphasize, as we will get into ultimately the pipeline and the activity that's driving and behind a lot of these advances, as well as the representing the assets or opportunities available for licensing and M&A, is that this isn't some monolithic entity. Although the checkpoint inhibitors are certainly driving what's going on here, there still continue to be, frankly, a disproportionate and large amount of vaccines, as well as all sorts of other modalities, whether they are the adoptive cell therapy approaches, whether they are BiTEs that are bispecific approaches, whether they are small molecule immunomodulatory agents directly discovered and positioned as IO agents, or, as many are doing, kind of a repositioning into the IO space, which in some cases may be a stretch, but in many cases probably is not, because at the end of the day, maybe almost everything, if not everything, including chemo and certainly radiation, work in part or owe part of their efficacy to the ability to ultimately lead to immunogenic cell death and to engage the immune system in recognition of various types of antigens, including neoantigens. So the idea that the IO agents are just somehow some frenzy that is similar to what was seen with approval of first targeted agents, whether small molecules or antibodies, is, I think, an unfair comparison, because really what these agents have been demonstrating initially in smaller subsets of population than ultimately we hope to achieve, but expanding as in different tumors or in combination, the ability to get better responses and longer responses across patients and different tumor types increases, but certainly the ability to demonstrate that a significant proportion, 15 or 20% of patients compared to those getting a standard of care, which in most cases is a chemo, whether DTIC or, as we'll talk about in lung cancer, et cetera, where you now truly have a targeted agent, even just as a monotherapy, that can kind of best the conventional standard of care and lead not only to response rates, but importantly, a significant, an increasingly significant number of patients that are having these long, durable remissions, or the tail end, as it's been called. And that tail that has been seen, and which people are trying to kind of push ever upwards, is a critical component, and some of the elements that go into thinking about that tail end probably go back to some of the interpretation or misinterpretation of, say, all the historical baggage of the failed vaccine trials, which, aside from anything else, including the lack of de-repression by not having a checkpoint inhibitor available, and many other aspects, probably didn't develop and follow those patients long enough to see the later term effects that some of those vaccines might have been able to have. So we're not talking just about a small difference here. We're ultimately talking about a very significant difference, qualitatively and quantitatively, that IO agents have been showing and continuing to show and increasingly show over the past 5 or 6 years. Certainly the evolution of biomarker, that is PD-L1, and I put that word biomarker in quotes, is continuing to evolve. But the ability to increase efficacy as one starts to combine just the IO agents, and certainly adding IO agents on top of standard of care, whether chemo or radiation, also has value, or on top of MTKIs has value. But just focusing in terms of, say, adding an anti-CTLA-4 and anti-PD-1, and being able to significantly increase, as one can see on the bottom right here, the percentage of durable responders, or even just looking at PFS as it goes up over time, is quite significant. And yes, there are tolerability issues, and maybe we'll touch on those a bit later. And now, having really demonstrated again, as was shown with Pembro, besting the taxane-based standard of care in non-small cell lung cancer first line, we really now have a series of, let's call them targeted agents, but of IO agents that are doing what was long kind of hoped for, that the original targeted agents, meaning small molecule TKIs, antibodies, et cetera, were hoping to do, which was somehow displace the conventional, broadly utilized, in most cases reasonably toxic types of cytotoxic, cytoreductive chemotherapies with a more tolerable type of targeted approach, such as IO. Not to say that they don't have their adverse events. There's certainly a different profile of adverse events, but increasingly one is seeing that these do have surprisingly good therapeutic indices, although certainly there are more and more reports coming out of kind of late-term sequelae, autoimmune type effects, which is, I don't think, ultimately surprising, and hopefully as we get better in understanding the dosage and dosing and sequencing of these agents, we will be able to better minimize those, just like the recent summer ASCO data in terms of the evolution of the dosing and sequencing and timing of administration of anti-CTLA-4, of IPI, and of Nivo, anti-PD-1, has demonstrated and will continue to demonstrate. So we're in a space where a lot of things are happening really fast, and any type of analysis we do for a client 3 months later may well be in part obviated because the rate of approval is quite so significant that it is, almost a daily event where one is seeing approval, a breakthrough designation, and certainly partnering deals of one sort, flavor, or another that are being announced. So very, very dynamic market, which makes it certainly challenging for any outsider that to keep track of, but also makes it very challenging for those on the inside trying to think about their clinical development and commercial strategies, because these things are evolving at such a tremendous pace. And aside from the rate of change, certainly with time in selected tumors, and hopefully, as we'll talk about, less and less just a selective subset of tumors, and hopefully more and more tumors will be subject to the issue of the rising bar or the rising benchmarks that IO agents are able to demonstrate becoming either in IO monotherapy or IO combination situations or IO plus non-IO combinations. The new standard of care, or at least a significant alternative standard of care, or a standard of care for a subset of designated patients across these different tumor types. And you can see here just a schematic mapping just by response rates of the key approved leading checkpoint inhibitors, both PD-1, L1, and anti-CTLA-4. And you can see the degree to which, over time and in comparison to standard of care, whether monotherapy versus doublet IO agents, or again standard of care chemo agents or other historical targeted agents such as Afinitor in RCC, for example, that the ORR as well as the outcomes in terms of mostly overall survival are increasing and increasingly having a larger percentage of patients, which is the hope that the combination approaches are offering out there to kind of convert more and more patients, whether in immunoresponsive tumors to capture more of those patients, or in the less immunoresponsive patients or the colder tumors, to try and again come up ways to convert those and begin to capture and obtain more and longer durable responses in those patients. Now, to the point of those who kind of are more skeptical or negative or waiting for the bubble on IO to burst, certainly there have been pinpricks, at the very least, some quite significant in terms of stumbles. So it's not like all the trials are reading out positive, certainly not all the monotherapy trials, and not even all the early signals on some of the combinations are what everyone would have hoped for. But what is certainly happening is that in many cases there is very positive, or at least kind of marginal data, and some of that marginal data might be due to monotherapy activity or otherwise. And you can see in the coding here where the kind of the moderate activity in orange with the asterisk is designated where it might have been a combo trial. Otherwise, it was a monotherapy trial. So certainly a lot of green, and if you consider green and orange, still a fair amount of positive activity, positive to very positive activity compared to the stumbles. But again, there have been stumbles and failures both historically and more recently. In particular, not to pick on this, but this is kind of the major clinical trial failing that is most on everyone's mind within the past few months, and this is to a great degree was driven by the PDL stratification or lack thereof, or the cutoff point that was used in this trial. But the point I want to make is simply that these will continue to happen because we are still learning on the jobs. Mistakes will be made both by virtue of unknown science as well as for other reasons. But by and large, these stumbles to date have not, let's say, as I said, some would be expecting, burst the bubble yet on what is the tremendous interest and activity in IO. And in fact, when you look at consensus analyst forecast, although there certainly was a big swapping of revenue projections pulled from Opdivo into Merck's camp for Keytruda, and still in most of the projections, the overall market continued to be quite sound, and still, frankly, Opdivo still does have the lion's share, again, when looking at consensus analyst forecasts across all the approved and anticipated approvals over the next over the next 7 to 10 years. So to understand and think about ultimately what we will be getting to in terms of the deal making, as I said before, it's very critical to understand that intersection of what I've been kind of alluding to before in terms of where we are in terms of benchmarking the activity of these agents across different tumor types and in different patients, and the range of opportunities that exist in the pipeline that ultimately are going to help to address whether increasing the ability to push up that bar on hot tumors, to address the issue of the cold tumors by trying to unlock and get TIL infiltration into those, et cetera, et cetera. All of those activity improving the outcome for patients, as well as driving the deal-making activity, come from the activity in the pipeline, and come from the fact that while as I said at the outset, the activity seen with these IO agents to date is both qualitatively and quantitatively different, the degree of activity does vary tremendously across tumor types, to some degree mapping, and I didn't put it in this current slide deck with the mutational load, but not completely. So that one does have this rough segmentation. This was borrowed from an earlier Citibank report between the more immunogenic or more immunoresponsive settings to those ultimately that are less immunoresponsive, and even now needing kind of a rethink of kind of the segmentation of the hematologic cancers, because if that's focused on just kind of a checkpoint inhibitor world, then certainly that concept has evolved from the idea of it, and checkpoints not working in myeloma to working phenomenally well when combined with IMiDs, as well as the applicability of other types of modalities such as CAR T cells or TCRs, and certainly of bispecific T cell redirecting agents like the Amgen Micromet BiTEs, et cetera. But one thing for sure is the sheer degree of activity in looking and exploring and studying combinations of these agents, with the recognition that in order to drive the percentage of responders up here beyond even what a CTLA-4 anti-PDX might be able to achieve, or certainly get more and more of these less immunoresponsive tumors to respond, that's where much of this activity is coming, whether directly driven by industry, co-sponsored with academia, or coming through investigator-initiated trials, looking at all sorts of combinations, whether checkpoints with each other, checkpoints with costimulatory agonists, checkpoints with standard of care chemo or radiation, triple combinations thereof, certainly combinations with vaccines, with MTKIs, with other types of IO modalities like toll agents, et cetera. So it's a huge diversity, as that opening schematic showed, of different types of agents and therapeutic modalities that are being studied and combined predominantly with checkpoints, which do constitute kind of what we'll call now the foundational component of IO regimens for the foreseeable future, and for the moment mostly defined by anti-PDX, either anti-PD-1 or PD-L1, although again the improved therapeutic index, as is being defined by changing the dosing and sequencing of anti-PDX plus anti-CTLA-4, may be able to secure more of a role ultimately for CTLA-4, which does have unique properties, especially in terms of T-cell priming, that the anti-PDX do not have, but which is still certainly dogged by a degree of baggage from, certainly from tolerability aspects. And so again, as I said, much of this activity does focus on, or is based off of the checkpoint inhibitors, and a lot of the costimulatory agonists, and you can see kind of the range of most common players right now that are being looked at, of not just the kind of the first-in checkpoints, if you will, but next generation, as well as costim agonists, and even some immunomodulatory small molecule agents like IDO, and innate targeting agents like targeting KIR, et cetera, and increasingly, some bispecifics that are looking at some of these combinations. And all these represent opportunities either individually or together have potential licensing or M&A opportunities because the number of anti-PDX agents is really quite considerable. So there's still a lot of we'll call them Me Too's, but not necessarily pejoratively, because it's possible there may be some differentiation in those, because for sure we've seen deals and internal development trying to advance the idea of improving on the checkpoints and their therapeutic indices, such as exemplified by BMS and CytomX deal, for example, with the probodies to mask whether an anti-CTLA-4 or an anti-PDX and have them only really operate in the appropriate tumor microenvironment. And again, just reiterating the degree of the programs, and you can see the checkpoint programs here on the left and the Costims on the right. We're starting to see glimmers and signals of activity, especially with IDO agents, but with others as well. And there are a number of early stage targets, TIGIT, VISTA, et cetera, who are considered by the IOKOL to be quite promising, that are still up and coming. And frankly, when you look at kind of a higher level, not surprisingly, there's a lot of activity with the antibodies, but still, as I said earlier, a huge amount of activity with vaccines of all flavors, because many of those had started, long before and have now been reinvigorated by the possibility of combinations with checkpoints. But when you do look at these combinations, a lot of the anti-PDX combinations are, not surprisingly, with CTLA-4, since we have that approved. And others that are moving along, but also on top of standard of care with kinase inhibitors and chemotherapies, et cetera, as I've said. The sheer number of activity, and again, this is very relevant to potential deal making, to biotechs thinking about clinical development strategy and positioning and trying to figure out how to demonstrate not just proof of concept, but as we call it, proof of relevance ultimately is, first of all, just understanding the magnitude of activity that's going on in the space right now, and that's really defined by just the huge number of trials that are ongoing. As I said, many of them in combination across, almost every tumor type, large and small, not just solid, but also heme, that one can think of, and it can be quite daunting to think about from a clinical development strategy, enrollment strategy, ultimately a commercial or pricing strategy, how a later in player, a late entry player, just in the checkpoint space, will be able to move a program forward and ultimately carve out some type of commercial sphere that's sufficiently commercially attractive for a return on an investment. And the pipeline that is ultimately feeding into the deal making that we'll talk about shortly is continue to be driven by increasing investment in IO within the pipeline. But that being said, IO is still a smaller proportion of the overall oncology pipeline than what we would at least still generally call non-IO, which is reflected here both in the kind of percentage range of IO, as well as, and clearly a number of these, you also get double counting because of how the databases work and drugs that are in development for multiple indications. But needless to say, we're talking about, maybe a third of the pipeline that is IO, and a lot of that is driven by biologics, which is a lot of where activity has been and success has been, certainly in oncology. But the amount of activity of biologics is quite disproportionate to the small molecules in IO versus the amount of activity in the non-IO side, where it's much more driven by small molecules. And that's not surprising, just given, again, the kind of the overall shift and balance that biologics have continued to demonstrate as blockbuster products, not just in oncology, but just across the whole therapeutic area spaces within healthcare. And to emphasize again the degree of challenges for clinical developers, most especially for smaller biotechs, but also again the the sheer number of opportunities for those that are on the buying side, just looking at the number of trials newly starting up by looking at clinicaltrials.gov is quite incredible when you look at, even just look at checkpoints and Costims in combination trials starting up, going back historically to, this would have been the dawn of leading into approval of Yervoy and ultimately Opdivo and Keytruda, and then you can see just the tremendous ramp up that happened just last year, and this was kind of year to date when this was done, which is actually already a couple of months ago when this particular analysis was done, I think for the talk that I gave at LES in Vancouver in early November. So, so the rate of activity is phenomenal in the space. And when you stand back and think about this, it's not only being driven by the scientific and ultimately clinical value of these combinations, but also by the franchise strategy and synergy that companies are looking at. And so I've referred to this as this combinatorial optionality, where different companies are playing out their optionality in different ways, whether it's across different targets and modalities, checkpoint, Costims, oncolytic viruses, or just a huge amount of diversity within those. Certainly the amount of diversity, both internal coming out of Medarex, as well as through deals, for example, that BMS has done across mostly the antibody space, and some in vaccine, not so much in the, and not so much in the oncolytic virus, or especially in the adoptive cell therapy space, whereas others have made more heavy commitments into adoptive cell therapy space. But the recognition that it may take more than just a combination of two checkpoints or a combination of a checkpoint and a Costim ultimately to get the type of clinical activity that we want. It may take more drivers of immunogenic cell death, danger signals, things to drive TIL in and not just de-repress them and not just activate, which would include certainly oncolytic viruses, toll receptors, innate agents, cytokines, chemokines, T cell and other immune cell trafficking, targeting agents, etc. And all of that, again, represents potential targets and activity for partnering. Not surprisingly, much of what's going on certainly is looking at advanced stage patients, as has happened historically, but with more and more of a move earlier into disease, not only for capturing more patients, but also hopefully for capturing more value, not in the financial sense, but in the sense of being able to have more an impact on patients, given the long-standing and held belief that going into earlier stage disease with IO agents is going to have a more significant impact at the end of the day. And that's also reflected in the kind of the speed with which many of these IO agents are gaining approval. And this is broadly true in oncology for sure, but especially true for many of these IO agents where they are leapfrogging either from phase 1 to phase 3, or certainly getting BT and accelerated types of approval. So that brings us all to a situation where we have continuing unmet needs despite some significant demonstration of efficacy that the first generation of IO agents, mostly the first generation of checkpoint inhibitors, have demonstrated, at least singly and more slowly and increasingly in combination. But also the realization that there are still, patients, even in melanoma, who are not being responsive or ultimately becoming not responsive to, say, a combination of an anti-PDX and a CTLA-4, or certainly in lung cancer or beyond, where, such as prostate cancer, where even certainly single agent IO agents and even some combination agents have had not as substantive effects as we would like. So being able to, again, diversify what those combinations may be, such as a checkpoint with a vaccine, for example, in the prostate cancer space, or the checkpoint with an oncolytic virus, etc., represents where clinically we need to go, represents where biotech and academia are going in terms of moving these next-generation targets, next-generation therapeutic modalities forward, and where the licensing and M&A and other types of collaborative arrangements are going on right now within mid and large biopharma within the IO space. And certainly when you look at just, kind of the numbers thrown around, these are, third-party sources other than us, like from Data Monitor, et cetera. A huge amount of certainly very significant upfront and kind of very large kind of bio world, if you will, dollars that are being put forward here. And the number of partnerships, just to give one an exemplar here of BMS over that kind of 4+ year period, in terms of how many, the 50 partnership deals, the majority of them aimed at some type of combination treatment, certainly not all of them outright cash on the barrel, but many that are collaborative types of structures with or without publicly announced rights at the end of those press releases. But when you take a snapshot look at what's gone on, just looking at last year in terms of the top deals in oncology and the top deals in IO, and the ones that are IO are certainly 90% of the top oncology deals, and so that is where everyone wants to be, and that drives more funding and startup of companies, aside from the clinical unmet needs, and certainly drives a continued frenzy. And I'm sure a number of these were bidding wars, and it's also going to drive some of the trends that we'll be talking about shortly in terms of the stage of the deals that are being done. Just as I said for the key events in terms of approvals that are becoming very hard to keep up with, let alone the announcements of of data that's coming out on a daily basis for these products, alone or in combination. The types of deal making similarly are very hard to keep up with, and this has not been updated since September, when we put this together for early on for my talk in Vancouver. So, and it's not representing everything, because that would be a complete eye chart. So, but it is reflecting a tremendous amount of deal-making activity of all sorts of flavors. But certainly one thing that is very significant is that many of these, and increasingly, are being done at an early stage. And that's one of the things that I think will be one of the key take-home messages, is how early people, it's always been, or it's increasingly been a trend within oncology for sure, but has been only accelerated by the tremendous interest in the immuno-oncology space. So whether it's the size of the deal relative to their early status, or the number of the deals, both of those metrics are going up and up. So whether it's, as represented here, this BMS deal on the anti-IL-8 antibody that Cormorant had, whether it's the Merck buyout of Iomed to gain access to that IDO, of which half a dozen deals were done by most of the major players, whether it's the potential rehabilitation of some of the early IO agents, such as interleukin-2, such as the pegylated IL-2 that Nektar has been developing, that this collaboration between BMS and Nektar points to, whether it's the advancing role of other targets and other pathways within the immune system that represent a place where the deal-making can occur, such as innate immunity, whether the original targets, say, a BMS with innate on KIR, or whether other NK cell surface targets, or say this Merck collaborative arrangement with BioThera for BioThera's Imprime, or increasingly the interest in neoantigens, going back to some of my earlier comments about the rough, and I emphasize rough, correlation of immunoresponsiveness with mutational load and presence of neoantigens, and ultimately potential TIL infiltration, and also oncolytic viruses, which have been around for a long time and have kind of mostly been waning until the past couple of years, when interest in them has quite reinvigorated, as the understanding, the development, and the engineering of the oncolytic viruses has shifted from solely being a kind of tumoricidal, tumorlytic type of concept, where the virus has preferential cell killing of the tumor relative to normal tissue, but the ability of these oncolytic viruses, regardless of how they may be carrying transgenes like Imlygic carrying GCSF or carrying in a specific antigen so they act like vaccines, they lead to immunogenic cell death and cell killing and release lots of danger signals, et cetera, that can really ramp up immune system, immune cell recruitment, chemokines, cytokines, et cetera. So the renewed interest not only in those oncolytic viruses, but also in this concept of the neoantigens, those antigens that are unique to each patient's particular tumor. Some may be shared between some patients, but the idea of trying to rehabilitate, if you will, the idea of vaccines, and instead of focusing on the tumor-associated or tumor-specific antigens to get away from some of the problems there with safety as well as problems with tolerance by identifying these neoantigens which may arise from unique and specific mutations, not solely in driver oncogenes, but in a variety of other targets. They may be mutations, they may be splice variants, et cetera. And so a lot of the activity that's happened, frankly, in the past year has been around, startups in both these spaces, newcos, or deal making, such as this Genentech BioNTech deal. The neoantigens are being approached in a variety of ways, one of which is kind of the intersection of the whole separate, not oncology specific frenzy around mRNA, and now this intersection of mRNA and neoantigens and the immuno-oncology driving many of those types of deals, or the Amgen Advaxis deal. And again, as I said, many of these new startups from Versant's Turnstone to the Celgene next-gen startup, or the Boehringer startup in EU, looking at a whole range of different types of viruses engineered in various ways, which all brings us back to a seller's market where any biotech or academic group ready to spin out into a new co has a tremendous amount of leverage by operating across this cancer immunity cycle in any number of pathways, not just in T cells, not just in effector T cells, but in Tregs, and as I said, innate immunity cells, NK, increasingly looking at tumor-associated macrophages, myeloid-derived suppressor cells, looking at more and more other targets within the tumor microenvironment, as well as understanding more about programs that we really didn't think of per se as immuno-oncology targets like anti-VEGF, including Avastin, but now we're understanding to have very important roles in terms of the tumor microenvironment. And so when you get to then starting to do some of the analytics that are kind of coming out from all that clinical development and pipeline activity, all trying to address those immunoresponsive tumors and to get more patients to have better and longer responses, and those less immunoresponsive, those colder tumors, you can see that just in looking in kind of the half year from January through June in terms of IO versus non-IO deal, that but when you add it all up, certainly much more IO licensing activity only that has gone on, especially right in the beginning of the year. And in fact, when you look at the kind of the distribution of oncology deals, although the number of non-IO deals still is greater than the IO deals, the value of the two are almost the same, with IO actually edging out non-IO, meaning that the overall value of those smaller number of IO deals is quite significant. And in fact, when you look at the kind of distribution of IO and non-IO deals, what you really see is that there is a huge amount of IO deal-making activity happening very early on. So in other words, a lot of desire amongst those that have extant franchises, those that may be kind of building up and anticipating an IO franchise, and those that maybe are still kind of on the outside periphery and not wanting to let this major event go by, like some of those players that stood very long, perhaps too long on the sidelines when the antibody value and number of companies and deals went on. So making this stake early on, gaining access to novel targets or modalities, especially by companies wanting to expand that combinatorial optionality, is driving a huge amount of early deal-making activity in the IO space, where you can see, you know, over the majority are happening at even a preclinical or research stage, whereas compared to the non-IO, you know, much more about clinical stage activity. And then if we drill down into that a bit, you can see that the amount of deal-making activity in IO is significantly higher than non-IO in these early stage, starts to really ratchet up by the time one's starting to enter phase 2, especially compared to non-IO, and then starts to flip around a bit as one gets into more advanced development, or in fact when there are marketed products leading to say major acquisitions. So that's just total deal value, and again is right in line with the amount of interest and the sheer number of assets and programs that are available early stage. So at the end of the day, what one really is hoping for, and we're at a point where we're seeing people make statements, cautionary statements in quotes, but statements nonetheless that, you know, were never really made before by anyone credible about the potential for curative approaches for curing cancers. Now that doesn't mean one-time treat and done. That might mean that there's some repeat treatment, but certainly what's been seen with kind of limited duration of therapy, both in trials and with the approved checkpoints, leading to kind of long tail end, increasingly significant percentage of patients starting at 15 to 20%, then getting in combinations up to, you know, 40, 50, 60%, et cetera. The idea that you may be able to have these long survivors, and many from the early trials with Ipi or Nivo or Pembro, you know, have in melanoma and increasingly in lung have been living, you know, for quite significant periods of time, and continuing to do so without even repeat treatment at this point. So the idea is, how do we get, you know, more of those patients in those cancers like RCC and bladder and lung and melanoma to achieve this, and then how do we try and extend the reach of those to the pancreatic cancers and the liver cancers and the prostate cancers, so that we can get to a large percentage of patients having these long durable remissions that either are, you know, akin to occur to a cure, or very much being able to be managed in some type of a chronic basis. And so, again, science fiction, we dream, but in science we dream too. And I think going back to, you know, Coley's early work, it's probably quite astounding to any of those, and I'm sure it's quite gratifying to the folks at, you know, to CRI or Helen Coley Knott had been instrumental, and all the others have been kind of toiling in this space for so long. So with that, I just want to thank the various consultants and analysts that have contributed in various ways to the data analytics that have gone into this presentation, and I will just ask if there are any questions, and it's very unusual for me to not go all the way up to the very hour. We actually have 10 minutes left if there are any questions. So again, thank you very much for your time. We'll wait a few minutes to see if there are any questions, and if not, we will.
Can they hear me?
Yeah.
Sorry. Thank you, Jeff. There are a bunch of them, and James is looking through. James, just pull one out and you can ask it.
Okay. So one question I think is very much on the minds of a lot of people that are maybe in the non-IO space specifically, and they're really interested to know what kind of approaches you might be able to combine IO with traditional chemotherapy and how that might be evolving in the future.
Sure, and as I won't jump around on the slides, but just to note that earlier kind of combination slide that I had does indicate that there is a lot of interest both in industry and academics in these combinations, driven not solely by just the kind of standard strategy of kind of layering on top of a standard of care, but also with the recognition that many of these types of agents, even chemo agents, do lead to the immunogenic type of cell death that can contribute to the appropriate immune environment, where if you are able to de-repress that tumor immunosuppression in the tumor microenvironment and get those TILs in and then activate those TILs in various ways. So certainly anyone who has a strictly truly non-IO agent that does not appear to in some way be abetting or enabling the immune system to counter the tumor microenvironment. And assuming that this is not a situation where those non-IO agents are directed to very specific targeted changes such as mutations, where there still may be a value to that development, although increasingly there is the recognition and the clinical data to support the broad utility of checkpoints and combinations, both in mutated and wild-type situations for some of these types of alterations. But certainly one has to consider whether you would have unique utility in patients that are progressing on single or combination checkpoint and inhibitors or IO agents, or whether you have some unique combination value, which maybe one can't necessarily demonstrate is directly tied to, say, immunogenic cell death, but may well be at the end of the day. So I think you certainly have to reckon with the changing standard of care that many of these IO agents are creating, but at the same time, there's lots of tumor types where they've only made incremental to, no advances as of yet. Now, many of those are the same tumors that have proven recalcitrant to targeted agents and others as well, like pancreatic or HCC. So I think what it suggests at the end of the day is one has to do, either in-house or externally, a very thorough examination of and prioritization of the potential tumor types that could be pursued, again, assuming there's no kind of mutationally driven rationale, to kind of understand, well, what are the white spaces, where are the unmet needs, what are the particularly unique refractory patient populations, as well as understanding how competitive, kind of the trial activity is in those spaces. But doing all that, there's still going to be a large number of industry players who are still going to say, well, my preference is to find an IO agent over a non-IO agent, but not everyone. There's certainly large players who continue to show and do deals that are non-IO, and there are certainly, sub-large, meaning medium or type players that do have an evinced interest in non-IO.
Great, thank you, Jeff.
James?
Yeah, there's another one that seems really interesting. So one of the questions is really just trying to predict what the future of IO is and deal making in 2017. Do you have any comments on that?
So say that again. Predict what particularly, mean the nature of the deals, or how many deals, or?
Yeah, how many deals, nature of the deals, in 2017. I mean, you showed a lot of the historical deals. We're just wondering about, what do you predict it will be like in 2017?
Well, I would be surprised if there was a significant diminution of deals. I mean, I think the issue here is that we're facing is that while there continue to be a huge number of different modalities and targets that are available that continue to drive deals, certainly amongst the major players, that at some point there's going to have to be some rationalization of resources and prioritization, because they certainly can't kind of go on licensing a huge number because it's going to take long enough and be hard enough to kind of explore the set of combinations, mostly still driven by empirical combinations that many of these have right now. So it's possible that might slow down for some of the kind of front and center, top, 2 or 3 players. But then there are still, the players in kind of the half tier down below that and the tier below that who still do need to expand their arsenal, or who are still hungry to get more squarely into IO, even if they realize that that's going to be more of a long-term play on their part, that they missed the first wave and are going to, and maybe the deal making is not going to even bring them into the second wave, that they might be into the ultimately kind of the third wave. Now, of course, the number of patients may begin to shrink with the first and second waves of agents. It remains to be seen yet. And that deal-making activity is also going to be dependent, I think, on what kind of events, news items get reported coming out of upcoming meetings and how positive those are. As if there are other stumbles, whether with extend agents or with novel targets, or the combinations start to show data that is not as stellar as one has hoped, you could kind of see that going either way. It could kind of dampen the fervor and kind of be something akin to those that are expecting the bubble to burst, or it could, simply reinforce the idea that, we need to have more and more different targets and modalities to kind of crack the nut, because the bottom line is we still don't, have, the majority of patients and the majority of tumors being, even in quotes, anywhere near cured or having long durable remission. So the unmet need remains, and as long as that remains to be true, there will be new targets and modalities being pursued, which will represent new opportunities for funding and for partnerships.
Thank you, Jeff. Your timing is perfect. We're just at the end of the hour. So we'll stop here, and again, if you submitted questions, we will get back to you in the next couple of days, and the slides and the audio, again, in a couple of days will be up on our website. And if any of you want to contact us, please feel free to do so, and we look forward to speaking with you, and have a nice day. Thank you, Jeff.
Yeah. Thank you, everyone, again, for your attendance, and thank you all the DHers who helped. Take care. Bye-bye. Happy holidays.
Bye.
Bye.